Hello, this is Amjad al-Mandilawi from Baghdad, Iraq. Today we are going to show a case of distal left main stem bifurcation critical lesion that seems to be difficult. And we are going to do the case with the cardiology board students. The primary operator is going to be with me, Dr. Ali Khalid, and he is going to present the case.
Our case today, a 70 years old male with diabetic, type 2, hypertensive, ex-smoker with history of ACS three months ago. When cath done at that time, we show a distal critical left main stem. Echo show a mild LV dysfunction, ejection fraction around 40. Now the patient complaining of recurrent attack of chest pain, even at rest. The patient referred for cabbage. He refused surgery and referred back from the surgeon for PCI.
So the usual scenario, a patient that is typical case for cabbage, but he refused. Actually, the surgeon contacted me with a patient that whether we can do anything for this patient. Let's review the coronary angiography of the patient. So it's clear, this is the angiography, diagnostic angio done with radial approach, distal left main stem, critical lesion, involving the ostia of both the circ and the LID, and there is some aneurysmal dilatation of the LID. And the circ, there is some critical lesion. If you go for the cranial view, there is some intermediate lesion in the LID that we need to address during the PCI. And this is the spider view. So, the angle between the circ and the LID, this is important, and also what is important is the angle between the left main and the LID. So Dr. Ali, what do you think first to start with? What guiding catheter are we going to take? So you prefer to take a good guiding catheter with good support. We may anticipate some difficulty
in the wiring of the LID
in wiring the
and
LID.
the circ mostly.
Yeah. The problem is with the angulation of the left circumflex. And we have to remember that there is another branch which is a small ramus here. So the wire may go directly into the ramus. So the first step, we take a good guiding catheter. What wire are you going to take, and which vessel are you going to wire first?
First we will wire the LID and then we will wire the circ.
Yeah, it seems that the LID probably is more significant and it's easier. The difficulty, as we said, is in wiring the circumflex. What can we do? What things that you can do to overcome this difficulty?
I think we preferably to take a secondary curve.
Yeah, that's one option.
If not passed with difficulty, we can take a micro catheter with a side branch.
Yeah. After wiring the LID, some secondary curve in the wire for the circumflex may suffice in crossing the circ. The other option is to take an angulating guiding catheter that may help crossing the circumflex. The last option is to change the plaque. We modify the plaque by balloon and change the angulation. That is, we dilate and then we cross the circumflex. So after we cross both vessels, now what we need? What is the next step?
Predilate.
So predilatation is very important. What do you think? Do you need an extensive predilatation? And do you need the high pressure balloon or what?
A large artery with calcification, I think we need a high pressure balloon to predilate this lesion.
Yeah, we need we need the high pressure balloon, and probably we need some cutting balloon. And maybe debulking, but in this large vessel, a debulking equipment would be mostly the rotablator. That is, it would not open up too much. You can take 1.5 or 0.75. It will only shave the plaque. So I think we are going to take, in addition to NC balloon, some cutting balloon, and the available here, I think it's a 3.5 balloon. After preparation of the system, of the lesion, now we come to stenting. What technique are you going to use for this left main stem bifurcation?
For this bifurcation, we have two options. Firstly, provisional diagnosis, provisional stenting. After stenting the left main LID, we will see the ostia of the circ. If not jeopardized, we will go with provisional stenting.
Yeah.
If the ostia jeopardized, we can go the T stenting, I think.
Yes, that's the recommendation of the European Bifurcation Club, that if you can go for a provisional, whenever you can go for a provisional stenting. That's okay. We are going to do a stenting LID and then check the circ ostium, probably after inflation, kissing inflation for the both, and after doing the pot. What do you think? What stent size we need for the left main LID? It is a large one.
Large one,
and we are going to
maybe 5. We
depend
depend on the
on-
IVUS imaging.
Yeah.
And
It's very important for such lesion, and in every left main stem, is to go for intravascular imaging. And that's what we are going to do to assess the size of the distal and the left main stem. Usually, we depend on the size of the distal reference vessels. But here,
we have
what we
aneurysmal
see
segment.
is some aneurysm of the LAD. So I think we need to size both and see what stent size we can put. At this part of the world, we have to make sure what stent we have, what balloon we have for pot before doing any procedure, and you have to make sure that they are available in the cath lab. So it's a distal bifurcation left main. We need to wire both. We are going for pre-dilatation, and we are going to do provisional stenting. Probably before stenting the left main LID, we are going to stent the circ, and the final thing we are going to do FFR for the LID. Okay? Shall we go?
yes.
We start the case. Dr. Ali Khalid did angiography, and he managed to engage the right coronary, which was not engaged by the radial approach. And there seems to be only an ostial plaque without a critical lesion. And now, if we give me the next picture, next. We took an EBU guiding catheter, 7 French, femoral approach. It's the same lesion as we discussed, the bifurcational distal left main stem with calcification. So we will start to take a Sion blue wire, trying to engage first the left main LID. So the primary operator, Dr. Ali Khalid, third-year cardiologist. I'm Amjad al-Mendelawi, assistant Maha, and you have Dr. Ali Hussein with us, and the technician Dhul Fiqar, and the radiologist Ismail. انسى الاسم يعني. اوكي كرينيال. واحدة الاخ واير سيون بلو. روح. اوكي. لا. اوكي روح بعد. اوكي. شوف ايده. تقدر تخليها جنبك بس لا على صدرك. Yeah. So wiring the LID was not difficult, and we anticipate some difficulty in wiring the circumflex. ارجع كودال. probably we need some secondary angle. And that's what we are doing. If you see, تقدر تسوي focus. Okay. بسرعة حضر لنا البالون. بالون 2.5. اكو ألم صدرك؟ اي ان سي. Go ahead. Go بسرعة. Maybe we close the. Okay, other remus. This is remus. اسحب. بعدين.
قلنا للدكتور.
دكتور شلون؟ بلغم. وين التخدير؟ خليه يجي يعطي جوزه. اي هسه يجيك. اسحب. اوكي. Yeah. Very good. لا. لا اكو برانش. اي اوكي. روحي شي روح. لا. دفع هسه. Okay, that's it. We'll take. We need to make. I think we need to make some way for the IVUS. So we are going to take balloon 2.5 20 for LED left main stem, and then take the IVUS. حضر الIVUS فيها. لا لسه سحبت الواير مع LED. تأكد منه. Okay. جيبها. منا ما مسحته. اوكي. جو. ما حضر اللايف بس.
اوكي. هاج ايمج.
روح. نحتاج ننفخ راسا. اوكي جو.
ايمج.
جو. شنو ايمج؟ اوكي انفخ.
8
20
10
سني
20
اوف. اسحب. اوكي. Do angio. Okay, I think we have enough room for the IVUS. Take it out. So we are pushing the IVUS catheter across the left main stem. Let's see the LED also. Go distal. So to analyze the pullback from the LED to the left main stem, this is the distal LED. You can see the plaque. The lumen of the distal LED is around 4.8. It's acceptable. Maybe we are going to do an FFR for that. This is the mid part. Maybe here is somewhat critical. The plaque is soft, just minor calcification. And then pulling back more proximal, we'll see more calcification, but good lumen, you see here. Yeah, the lumen is okay. Let's see the proximal LID, and this is the aneurysm, or let's say the ectatic part. It is very wide with minimal plaque. And this is, here start the lesion. But if we measure this part, Yeah, it's around 5, 4.8. And the other line, 5. So it's around 5 millimeter. And here comes the ostial LAD. This is the wire of the circ. And this is the left main stem. There is calcification around 270 degrees. But probably there is some crack here that we can use some high pressure balloon to open it. Let's see. If I don't think we can take a rotowire or anything like that. Let's see the main stem itself, diameter. Again, it's 5 millimeter. So if we use a 5 millimeter stent, okay. Now we can analyze the length since we are doing automatic pullback. The ostium of the left main stem is clear, and we can put a stent up just before the ostium here, and the LAD up to this point. So let's measure the length by IVUS and see what stent do we have. Of course, after more pre-dilatation. So an 18-20 would be enough. Okay, now we have all the information. We need the further dilatation of the distal left main stem. Let's see if we can crack this part. So we have to take, do we have cutting balloon? So maybe we take a cutting balloon 3.5. This is the largest one cutting balloon we have. Okay. We're taking an Wolverine cutting balloon, Wolverine 3.5 15. Let's see how compliant is it. Okay. ايش قد نعمل 6 كودل طينا كودل شيل رجلك. Okay. Go. Difficult. Maybe the circ wire. لا اسحب. روح مرة الأخ. وين ده يقف؟ بالنص؟ بس لا تعوج الواير. Yeah, okay. Sure, let me see. So it's not easy to pass the Wolverine into the mid-circ, I think, the mid-left main stem. Okay, let's see if we have intermingled wire. Yeah, most probably. Yeah, mostly the wires are intermingled here. Okay, we passed, but now we have to we'll take out the circ wire. I think it's damaged. It has been intermingled by the other wire. Tiny test. Give me test, okay? Okay, okay, go.
Nominal 6.
Okay.
6.
Off. I'll pull back the balloon a little. Yeah, go 6.
6.
12. Pressure is coming down.
12.
Opening well. Off.
down.
Yeah. Catching up the pressure, now recovering. It was 80, now around 100. Yeah, let's give tests. عليك كيف؟ Okay, angio. اسحب داي. Another wire. Cyan blue. Okay, good. شوف هذا اللي يعلق. Let's try to rewire the circumflex. Yeah. And I think we are going to do IVUS for the circ for two reasons. To see at the mid part, maybe we need to stent it before stenting the left main. And the other is to look at the ostium. Okay, that was not difficult. So IVUS for the circ. Okay. يلا هذا الله يدي بقي. So the pressure now is 130. It came down to around 70 when we inflated the left main stem. Imaging دور فقار.
Okay, still.
Go. Okay, go. تمام. فعل guide.
Some difficulty.
Push the guide a little. More. Okay. آخر محمد. Imaging. Okay, little bit more. بعد. Okay.
Okay.
Stop, pull back. Now camera on the IVUS. So the distal part, there was a landing zone, okay. It's around 3 millimeter. This is the critical part. Again, there is some calcification. So it is critical. I think we need to stent the circ before doing anything to the left main. Let's see the ostium. Sini. Okay. The proximal part of the circ. We have some landing zone here. And this is the proximal part, I think this one, yeah. Bifurcation, left main stem. Okay, stop recording. We are going to predilate the circ, the mid part, needs some predilatation. Balloon 2.520. The proximal circ looks okay, although there is some plaque at the ostium. Okay, test. Okay, inflate here.
Nominal 12.
Go 12.
12.
Sini. Okay, 14, 16.
16.
اوف. اعطيني صورة قبلها. بعد واحدة. اوكي. اوكي اسحب. انجو. Less size by the balloon.
Okay, ready.
Yeah. So if we avoid that part, can we? 20. 23 عندك؟ So we'll take 2.75, 38 for the circ. Go caudal again. Okay. Okay. Go distal.
I think it's okay.
It's okay. More. Go more. Cut. Test. Okay, let's do angio.
Okay.
Yeah, that's good. Perfect. Inflate.
No,
good
now
now.
12.
12,
Go 14.
14,
Just 14. Okay.
just 14.
Off. Take it out and do some angio. Okay. Angio. Perfect. So let's decide about the left main. So we decided to take a stent of 5. What size, what length do you have? 5 millimeter stent?
5 millimeter.
احنا قلنا we said 20 or more?
19.
Okay.
I was.
So we are going to take a stent of 5 millimeter for LID left main. But the length, there is some doubt. So we are going to take a balloon that is 20 just to make some sizing, because for post dilatation, the balloon that we have in the cath lab is 50 millimeter. So we should be able to cover that with post dilatation. So now we are going to size just the length. Push the balloon. Okay. Angio. So this is 20. If we take 22 that we have now at the cath lab, that would be okay. If we take 26, it's also going to be okay. Let's take RIO caudal view, because the proximal LID is a little bit foreshortened here. Okay. Angio. 24 would be good, but we have 22 and 26, right? Zulfiqar?
26 now.
Yeah. I think I'm going to take 26. Yeah.
Okay.
Okay, 26. Okay, stent 5 millimeter in diameter, 26 in length. We are going to cover both the LID and up to near the ostium, I think, for the left main stem. Okay, that's good. Test. Angio. Angio أحسن لازم. Pull it back a little bit. Yeah. Angio again. Do you want to see in another view? Let's see. Go fishbone. No.
Distal? Distal?
Distal we are covering here. We'll get the spine, the proximal LID, angio. Okay. That's good. Okay. Inflate. Nominal is good.
12.
Go 12. Sini. Stop. Perfect inflation. Off. Again, the pressure is coming down. The dye should be diluted. You see, it takes a long time to come down. Now the pressure is 90. It was 130. Yeah. Because we need to inflate more. What was the inflation pressure? 12?
12.
Let it have some rest. The pressure is covering, is recovering. Okay. Go 14.
14. 5.15.
Off. ألم صدرك؟ هسه يروح. So it's important to do the inflation twice so that the balloon will take its real size. Otherwise, there will be some under expansion. Now it's okay. The pressure came down and is recovering again. Okay. Pull out the balloon. You may see some difficulty because it's a large balloon. I say it's good. Okay, take it out. أحسن هسه؟ الحمد لله زين حجي. أي فتحناه. أي. Flora. Okay. Go. Good. We have some jeopardy in the jeopardization of the ostium of the circ. Probably before doing pot, or we need to recross. The pot we are going to do by balloon 5, the left main diameter was really 5, so I think the stent is just covering the left main diameter, and we don't need to go more than that. But probably we need to go more for the aneurysmal part of the LID. Okay. I think we are going to take a third wire to recross. We decided on a provisional stenting. So the wire goes to LID and we try to go to the most distal strut part of the bifurcation. Yes, okay. Test, let me see. Probably we need some larger angle. No. You have to free the wire. The wire should be free. It doesn't look free to me. Let me see. Wait, give it.
We need secondary.
Okay.
Test. Let's do angio here. There is a small area to decide whether we are distal strut or proximal. It seems to be okay. So you have to open the struts of the circ. Balloon 2. Yes. Balloon 2. Which one is the circ? With torque?
With the torque.
Okay.
I'm second time here.
Okay.
Okay.
Out.
Take this wire out, yes. Okay, this is the circ, balloon 2. And then we take 2.5. Maybe we do pot, side pot. We didn't do the first pot. We are going to do inflation at the ostium of the circ by balloon 2. Where is it?
Balloon.
2 millimeter. 220. 215. It's okay. Okay, let's see if a balloon 2 millimeter will pass. If not, we are going to take a smaller balloon, 1.5. I think it will go. Yeah, very good. That's it. Pull it back a little. Okay, inflate.
No, 12. 12.
14. What is the
14.
burst?
20.
Go 20.
20.
Sini. Off. Okay, take it out. Now we take balloon 2.5
2.5.
for the circ and 5 for the LED, left man. Open another inflation device.
Okay.
حافظ الوايرات.
2.5.
اوكي
15.
اي كل زين. So now we are parking both balloons, 2.5 15 in the circ, and we took a balloon 5 by 15 in the LED. We are going to post-dilate the LED stent first. Push the stent a little. Let's see the distal part that need more dilatation. Enough. Okay, go. The normal pressure is 10. Go to 16.
10. 16.
Sini. Off. Pull it back to the bifurcation. Take a long time this balloon to deflate. Okay, pull it back a little. Okay, go to 10. Wait. 12.
12.
16.
16.
Off. Okay, now let's inflate the ostium of the circ. Not now, wait. Pull back the balloon. No, not this one. Keep it here. Keep the left main. Just pull back the circ balloon. Yes, more. Yeah, that's it. Go. 12.
12.
20.
20.
So high pressure inflation, Sini, for the circ ostium off. اي ما يخالف حجي من عندنا هاي. Yeah, fluoro. Okay, let's go for kissing. Both for 10. 10.
10. 10.
Sini. You are 10?
Yes.
Off. ما يخالف حجي هسه راح يخلص. Okay, take out the balloon of the circ. And let's go for pot. Only the circ. Yeah. And we have to do pot for the before the bifurcation. We have to give some dye to make sure we are not at the carina. Push the balloon. Push. ادفع. Yeah. Pull it a little bit. بعد pull.
Okay.
Let's do some angio. Yeah, that's good. Okay, go to 16.
Fluoro. 16.
Off.
Pleasure.
Yeah. Off.
Deflate.
Yeah, okay. Now take out everything. Take the balloons out before doing angiography. Now we have to decide for two things. One is the ostium of the circ, and the other is the mid and distal LID. If there is no extensive dissection at the ostium of the circ, probably we are going to do just an FFR, and we are going to do an FFR for the LID. Okay, test. اوكي الويرة الزينة من الكاثتر شوي يدفع الجايد شوي يدفعه مو هاي. اوكي انجو. Yeah, there is some haziness at the ostium of the circ. Do you think we need to put a stent here? Thin spider. Okay. Angio. Yeah, maybe we need to put a stent, huh? What do you say?
Yes.
Possibility
Possibility of dissection.
Yeah, there is some dissection. It's no problem, but we feel more comfortable if we do a T-stenting, huh?
Yes.
Okay. طيب give me the picture before. الصورة اللي قبلها. شي رجلك. Yeah. So what stent قبلها? Three, 15, 12. طين صورة قبلها.
The bare area?
بعد قبلها. بعد. هاي 15. بعد قبلها. بعد. 12 would be enough, huh?
Just
Yeah,
all
we
the
leave a
ostium?
bare area. You want to cover it all? All circ? The last balloon was 15, huh? So we decided to take a stent 3.5, 3 by 24 with overlap with the distal distal stent of the circ. Now we have to do just T-stenting. We try just to put it at the edge of the left main stem stent. So we are going to do stent boost to see that. Bad. Okay. Okay, Sini. So we have minimal protrusion. I think this position is very good. Okay? افتح الضوء. Inflate. Fluoro.
11.
10.
11.
Sini. 10. Okay, 11, 12. Okay, off. Off.
Nominal 11.
With that said, I think we don't need to intervene any more. So usually you put a parking balloon in the left main LID, and then you may do a kissing inflation. I think here we don't need. It's a wide area. We have inflated the LID left main by 5 millimeter balloon. Let's see. Pull out the balloon. So we are going to do FFR for the LID. The FFR system we are using is the True Physio, which is microcatheter based. So this is it. We have to flush the system first completely. Wait for a few seconds until it is soaked. Then we zero the system. We already zeroed the aorta with the system. Go. So we started, we zeroed the catheter. Then let's take it. It's a low profile, about 1.5 millimeter catheter. The transducer is at the tip. We can keep our wire inside and go in and out whatever time you need. Okay, go. Open the 2E. Go. Okay, go. So we have two dots, 3 millimeter apart. Once we go out, stop here, out of the guiding cath, we equalize the pressure. Just wait a minute. Let's pull back the guiding a little bit. Okay. Pull the catheter a little bit. No, just say the microcatheter. Okay, that's it. Now equalize. Both the pressure waveform should conform one to each other and should be the same, and the PD over PA1. So it's 1, perfect. Now we go distal. Push the catheter distal, okay. Go. To the point of interest. It is the distal LAD. Yes, it is 93. So now we can give adenosine to make sure, but usually when it is more than 90, it's okay. Give me adenosine. We have already emptied the catheter from dye. I think we can give 120 microgram from the beginning. So we are going to give 120 microgram with rapid flush. When I tell you, make record. Record. حاجي راح تحس بخنقة صغيرة. So it's now 85. Yeah, at 84. So it seems that the LAD distal lesion is not significant. Now recovering. What do you say? Shall we give a larger dose? Or we stop here? Maybe you can give 180 micrograms. Stop recording. هذا شنو؟ So I'm going to give a larger dose, about 180 microgram of adenosine. And record. Oh, you were late recording. It's okay. It is 0.83. So still we are in the non-ischemic zone, let's say. Maybe it's in the borderline zone from 0.8 to 0.85. I think with such complexity in the left main stem and circ, maybe we avoid stenting the LAD. So before finishing the case, let's go pull back the microcatheter. Pull back, let's see if it's recovered. Yes, okay. Okay. There should be no drift, or at least 0.03 when we go to the left main stem. Okay, so we are going back to 1, so there is no drift. Stop recording, take out the catheter. I think so far so good for the LAD. We are going to do IVUS now for the stent and the LAD. So we did a pullback IVUS from the LAD to the left main stem. This is just at the aneurysm. You see, we are covering just at the ostium. So the stent is fully expanded. And actually, this is the larger balloon that we have. And this is the proximal part. This is the circ ostium. There is minimal protrusion. And this is the left main stem. The result looks okay. And this is the mid part, left main stem. Let's see. We are just short of the ostium. That is good. Let's review. If we see the bifurcation, this is the wire of the circ. And this is the bifurcation. So the circ is widely open. Probably this is some strut of the circ entering into the left main stem. So no much protrusion into the left main stem. And this is the distal part. Stop. So we are going to do the final angiography. Okay, angio. Yeah, that's good. Yeah, the LED looks critical, but we have to depend on the FFR. And whatever is done, we can stent later on at any other time if the patient is still going to be symptomatic. But physiologically speaking, depending on the FFR, is not significant. Frontal caudal. Otherwise, it's not a difficult job to stent it. Okay, angio. Yes, and the circ is very good. And by this, we conclude the case. And thank you.